Hi there, it's Alexandra Parsons here presenting my evidence-based, client-centered exercise prescription for David Keegan. Before developing an exercise program, it is essential to gain a good understanding of the client's medical history, to be able to evaluate their current health condition and identify their need for an exercise intervention, as well as identifying factors that will influence and guide your exercise prescription. The main findings in David's medical history is his recent stroke and history of TIAs. David suffered from a embolic stroke in March, where he was rushed to hospital. Testing showed focal hyperdensity of the right M1 segment of the middle cerebral artery. Treatment was immediate, with the clot initially being dissolved, then removed by an endovascular procedure. Following this procedure, David was kept in the high dependency for 10 days to ensure he could be closely monitored. He was then moved to the Stage 2 stroke unit for 12 weeks, where he was provided with inpatient physiotherapy, with the aim to return to full function. When discharged, David still had some residual hemiparesis, and loss of sensation remained in his left arm, lower leg, and foot. 8 months post his stroke, David still remains with decreased functional capacity, including weakness in his left hip and knee musculature, sensory loss in his left foot and leg, balance impairment, decreased control of the left shoulder girdle, decreased strength and function of left elbow, mild speech difficulties, signs of depression, spasticity signs in left elbow flexors, and only has the ability to walk slowly unassisted for 25 meters. These current health circumstances will be of particular importance when developing an exercise program for David. It is also important to take into consideration any other medical condition to gain a full understanding of David's current health. This will help to ensure David is able to participate in exercise, highlights any conditions that may need to be taken into consideration when implementing exercise, and can help direct goals for exercise intervention. David has previously been diagnosed with hypertension, type 2 diabetes, osteoarthritis of the left knee, and generalized anxiety. Other important components include David's body composition. He currently has a BMI of 34.8, which means he is classified as obese. He also has a waist-to-hip ratio that indicates abdominal obesity. Additionally, when gathering background information, it is also important to find out what medication the client is taking, due to its possible side effects on the individual, as well as the effects they can have on exercise participation. After gathering background knowledge of the client's medical history, as an AEP we have the ability to analyze their current health condition and identify possible short and long-term health concerns that may arise. Due to David's recent stroke, age, and other medical history, there is a variety of possible future health concerns. Short-term concerns are mainly related to current side effects of the stroke, with the main concerns being decreased mobility and strength, fatigue, balance impairments, and mood changes, as these can all have significant effects on David's physical and psychological function, leading to cascade health effects and decreasing David's overall quality of life. Later chronic effects refer to health concerns that may occur many years after treatment and may be persistent for an extensive period of time. A history of stroke and TIA, increased BMI, type 2 diabetes, as well as increased age places David at high risk for many health concerns. In particular, he is at increased risk of secondary disease such as cardiovascular or renal disease, as well as stroke recurrence. David's decreased mobility due to decreased strength, balance, and flexibility also places him at risk for falls, which is of particular concern due to the significant impact they can have on health and quality of life. When implementing an exercise program, it is important to ensure you tailor the exercise program around the needs of the clients to achieve the desired health outcomes and improve quality of life. Regular physical activity can have significant benefits on David's stroke recovery, body composition, diabetes management, and his psychological well-being. Muscle weakness is a significant negative sequel after stroke that contributes to chronic disability in survivors, with the weakness in the lower limb having strong correlation with gait velocity, standing performance, transferring, and stair climbing abilities. Studies have shown that regular resistance training can have significant improvements for stroke patients who suffer from hemiparesis, improving strength in the affected and non-affected leg, leading to enhanced functional mobility and quality of life. Aerobic training has also proven to be significantly beneficial for stroke patients since the average functional capacity for stroke clients is 14.4 milliliters per kilogram per minute, whereas 20 milliliters per kilo per minute is the minimum for independent living. Regular physical activity can help survivors increase their functional capacity, ultimately increasing their ability to live independently. Ultimately, exercise will lead to numerous benefits for David's health and overall well-being. Implementing a multidisciplinary team can ensure David receives the best possible care by providing him with a wide range of services. Incorporating a variety of services has the potential of improving David's quality of life and increases the likelihood of returning to pre-stroke function. Two allied health professionals that could contribute to David's rehabilitation is a dietitian and psychiatrist. David would benefit from a dietitian as they can provide support and education about healthy food options and strategies to manage his current weight. A dietitian can also help David manage his fatigue, improve overall nutrition, as well as provide assistance with his type 2 diabetes management, ultimately reducing David's risk of secondary disease, increasing overall health and his quality of life. A psychologist can also be helpful for David. They can provide support not only for himself but also his wife with adjusting to life changes. A psychologist can also help David throughout his recovery by helping to promote healthy behaviors, prevent disease, and improve quality of life. They can also provide recommendations and strategies to prevent and manage David's possible depression and his anxiety. When implementing an exercise program, it is important to take in consideration potential exercise-induced complications and have in place strategies to manage exercise risks. Taking into consideration David's age and past and current health, there are four main factors that need to be taken into consideration, including cardiopulmonary risk, especially in relation to his hypertension, cognitive impairments, falls risk, and risk of hypoglycemia. To reduce risk and avoid complications, it is important to put in place strategies during exercise. Strategies that will be incorporated into David's exercise intervention include monitoring David during training and recovery for any signs of cardiovascular effects, as well as ensuring progression is gradual, avoiding any large increases in any of the FIT principles to help maintain blood pressure, using equipment and assistive devices, as well as getting David to wear a safety belt during certain tasks, will also be beneficial to help prevent falls. To manage possible cognitive impairments, exercise will be explained in detail, providing a demonstration of each task. Additionally, being aware of David's type 2 diabetes is important to ensure he does not become hypoglycemic. Being aware of his medication and schedule will help to manage this. Performing tests and assessments with clients can help evaluate their health-related fitness and current health status. I'm going to outline 3 different tests that could be performed to assess David prior to commencing an exercise program. The first one is a timed up and go. The purpose of this assessment is to assess balance, functional mobility, gait, vestibular function, and falls risk. The test requires David to rise from an armchair, walk to a 3 meters away, turn, and return to a seated position in the chair, while being timed. It is expected that David would take approximately 18 to 20 seconds, significantly falling outside his age-related norms, demonstrating decreased strength, balance, and gait efficiency. This score would also indicate that David is at a risk of falls, as a study by Addison et al. Demonstrated a score greater than 14 seconds is indicative of falls risk. Exercise intervention should aim at improving David's strength, balance, and gait, with the aim to decrease falls risk, improve mobility and function based on these test results. Another test that is generally used in the elderly population is a 30-second sit-to-stand. This test requires David to start in a seated position and stand while keeping hands across his chest, then return to a seated position as many times as possible. This will assess David's lower limb strength and functional mobility. It has been proven to be a valid and reliable test, with sit-to-stand scores strongly correlating to maximum lower limb strength. The normative data for David's gender and age is 11 to 17. It is expected that David would fall below these norms due to his current stroke and reduced functional capacity, scoring approximately a 6 to 7. This would demonstrate that David has decreased strength, stability, and mobility in his lower limbs. This test identifies the need to incorporate lower limb strengthening training in the exercise program to not only increase mobility and functional capacity, but also to decrease progression of osteoarthritis and falls risk. Finally, the last assessment to be performed is the modified Ashworth scale. This scale helps to identify and measure the amount of muscle spasticity in upper and lower limbs during passive soft tissue stretching. The test is performed in the supine position by moving the limb at a speed of gravity for a maximum of 3 times for each joint, due to the short-term effect stretch can have on the score. While there is no normative data for this scale, it can be beneficial in identifying limbs with spasticity, as well as assessing the effects of exercise intervention on spasticity. It is expected that David's scores are 0 in all muscle limbs except for in the left elbow. It is expected that David would score +1 for the left elbow, meaning there was a slight increase in muscle tone, manifested by a catch, followed by minimal resistance throughout the remainder of the range of motion. This will demonstrate that David has experienced some spasticity in his left elbow, requiring attention in the exercise program. Incorporating strength and flexibility training for this limb will be of importance to help decrease the effects and progression of spasticity to help improve ability to perform tasks of daily living and quality of life. Setting goals for an exercise program can help motivate clients and also help to provide direction. When implementing goals, it is important to ensure that they are SMART goals, that is, specific, measurable, attainable, realistic, and within a time frame. Short-term goals usually focus on behavior change, while long-term goals focus on health outcomes and the successfulness of the exercise program. Setting a short-term goal such as participating in 3 exercise sessions a week can help encourage David to make behavior changes and encourage him to participate in exercise regularly, while setting a long-term goal such as decreasing weight and hip-to-waist ratio again helps to provide motivation, but also helps David to track his progression and see the effects and benefits exercise is having on his health. Moving on to David's exercise prescription, it is important to ensure the program addresses the major goals and priority health outcomes. The main focus of David's exercise program is to reduce his BMI, increase strength and endurance, as well as balance and mobility. These focuses will ultimately improve functional capacity and mobility, decrease the risk of falls, reduce the risk of secondary disease and stroke reoccurrence by improving David's overall quality of life. Due to being deconditioned, the exercise guidelines for stroke patients is slightly different to the general population. Aerobic exercise should be performed 3 to 5 days per week at intensity equivalent to a RPE of 11 to 13 for a duration of 15 to 30 minutes. RPE is used instead of intensity by heart rate due to the biomechanical limitations of stroke patients. While resistance exercise training should include all major muscle groups and functional exercise and be performed 3 to 5 days per week. It is safe for stroke patients to increase their intensity of resistance training up to 80% of 1 repetition max. However, training should start low and progress as tolerated. Additionally, flexibility training should be incorporated to improve range of motion of involved extremities and prevent contractures. It should be performed 3 to 5 days per week at intensity below point of discomfort, and again should be progressed as tolerated. There should also be an emphasis on stretching muscles on the paritic side, particularly in muscle groups experiencing spasticity. These guidelines have been incorporated into David's exercise program using an 8-week periodization model with 2 times 4-week macro cycles. A periodization program uses planned variations in intensity, volume, duration, and type to minimize fatigue and maximize performance outcomes. This is achieved throughout the macro cycles by incorporating exercise progression across weeks 1 and 3 and 5 and 7, and regressing in weeks 4 and 8 to allow for rest and recovery. Progression has been achieved by increasing the intensity, frequency, including sessions, reps, and sets, type, and duration of the exercises. For example, it can be seen in the first macro cycle that David's aerobic exercises are mainly at an RPE of 10 to 11, but slowly increase in the first 3 weeks to 12 to 13, then decrease in the 4th week to allow for recovery. This progression can also be seen when looking at the prescribed resistance exercises. Sets and reps are increased in addition to intensity and type of exercises. By implementing a periodization program, we can ensure David is continually making gains throughout the exercise, as well as avoid overtraining and fatigue. While there is a session that focuses on flexibility, stretching should be performed before or after each session, holding stretches for a minimum of 30 seconds and performing them 3 times for each muscle group. In addition to the prescribed exercises, David should try to go for a few light short walks every other day, building from 5 minutes up to 15 to 30 to help with recovery and maximize the benefits of exercises. Stretching and balance activities at home should also be encouraged. The second 4-week macro cycle follows the same principles of periodization. However, a noticeable difference is the progression in exercise types. For example, the sit to stand has now progressed to Swiss ball wall squats, normal squats, and lunges, while balance exercises now incorporate catching activities and closed eyes. That brings us to the end of the presentation, acknowledging the research that was used throughout. So thank you for listening and goodbye.